Hi, my name is Tina Shelton. I am the Orange County and Los Angeles Development Manager at Susan G. Komen. Thank you for joining us today's session about triple negative breast cancer, presented by Dr. Bhavana Pathak, Medical Oncologist, Memorial Care Institute at BreastLink. Dr. Pathak earned her medical degree from Boston University School of Medicine and completed fellowship training in oncology and hematology at the University of California Irvine Medical Center in Orange, California. Dr. Pathak has authored multiple research publications and has presented her work at many prestigious national conferences, with much of her studies focusing on health and wellness and resilience, as well as training in trauma-informed yoga. Throughout her academic career, she was a recipient of several awards and grants, and currently Dr. Pathak is a member of several professional societies. Dr. Pathak is fluent in multiple languages. She is classically trained soprano singer and enjoys singing Indian classical music. In her free time, she enjoys painting, dance, and travel. She has a son and a little one on the way. Dr. Pathak is committed to providing patient-centered care to all of her patients at BreastLink, helping them to make the most informed decisions about their health care. I present to you Dr. Bhavana Pathak.
Thank you so much, Tina, for that incredibly sweet and kind introduction. So today I'm going to be talking to you about metastatic triple-negative breast cancer. But I'd like to start first with what is the definition of triple-negative breast cancer? While most breast cancers are tested for the three most common prognostic and predictive markers, estrogen, progesterone, and HER2, triple-negative breast cancer is defined by the absence of these biomarkers, which becomes relevant as these biomarkers are the predominant forms of available targeted treatment. In terms of the epidemiology of triple-negative breast cancer, it comprises about 15% of breast cancer cases, with about 200,000 cases annually. It tends to be more common in younger women less than age 40, with an odds ratio of about 2.13. And although triple-negative breast cancer can affect women of all races, Black women, if they develop breast cancer, are more likely to have triple-negative breast cancer, with an odds ratio of about 2.41. In terms of risk factors for triple-negative breast cancer, having a positive breast cancer susceptibility gene, such as the BRCA gene, is certainly a risk factor, with up to 20% of triple-negative cases harboring a BRCA gene, such as BRCA1. Many of you have been maybe familiar with Angelina Jolie's case, where she had a BRCA1 mutation and decided to undergo a double mastectomy. In terms of other risk factors we've mentioned, African American women who are premenopausal, often at diagnosis. And then lastly, there's less validated data around obesity and having a younger age at first pregnancy in terms of contributing to the risk of TNBC. Now, in terms of the pathologic characteristics of triple-negative breast cancer, this is what we talk about when we get a sample of the breast cancer tissue, and analyze it under the microscope with our pathologist. We often see that these cancers tend to be higher grade. And what does that mean? So grading refers to how similar a cell and a cancer cell might be to its normal cell of origin. So how similar is this breast cancer cell to a normal breast cell? And so the higher the grade, the more dissimilar it is to a normal breast cell, which can mean that it can grow more quickly and it can also spread more easily. Now, I mentioned molecular subtype, and this refers to, with the advancement of our technology, we've been able to analyze the DNA and RNA of triple-negative breast cancer cells. And we've identified that in general, there are several different subtypes. And while previously this was often used in research settings, there has been a couple different subtypes that have emerged that actually have treatment implications. So while the basal subtype is often seen with triple-negative breast cancer, luminal androgen receptor subtype can affect which treatments women get. So they may be chosen to receive anti-androgen therapy instead of traditional therapies otherwise. And then lastly, in terms of the biology of triple negative breast cancer, we have been able to conduct what's called gene profiling assays. And we noticed that triple negative breast cancers, they happen to harbor, as I mentioned before, a lot of pathogenic mutations in these tumor suppressor genes. And so basically, what that means is that they tend to be susceptible to damaging the DNA of those cells. And so DNA damaging treatments, such as chemotherapies made out of what we call platinum agents, can be very can be successful in eradicating these tumors. And we can talk about that a little bit more later as there's emerging information about the role of these types of therapies. Now, in terms of diagnostic considerations for triple negative breast cancer, one major thing we always advocate for is genetic testing for breast cancer susceptibility, particularly the BRCA gene. Now, some may say just test anybody who has triple negative breast cancer, but some of the guidelines say, if you're less than 60 with a localized triple negative breast cancer, or really any age with metastatic TNBC, regardless of your family history. Another diagnostic consideration is that when patients with metastatic disease, breast cancer, either have a recurrence or new development, we always want to make sure, especially if they have a primary tumor in place and they develop a new disease, that we biopsy this metastatic site or a new site, because there tends to be actually a discordance between the primary and metastatic site. And there are variable reports of this incident, somewhere settling around 13% or so of, your primary tumor might be triple negative, but the metastatic site may or may not be, or vice versa. And so that certainly has implications in terms of treatment. Patient comes to me with evidence of disease, triple negative breast cancer, in multiple parts of their body, particularly what we said, the visceral organs, then we, as in any case, we want to act quickly, but particularly to protect, the organ function. Before all of this, we say that, chemotherapy, a multiple agent chemotherapy might be what is needed. But if we, as we generally do, have some time to at least figure out some of the features of your individual tumor, then we like to know a couple different and very, very important facts in terms of the tumor biology. And so some of these words may not make sense to you now, but I hope they do at the end of our talk. So we basically want to know if you have positive for the PD-L1 receptor or negative, because that will really put you down a path, as I alluded to, of, with the recent advent of immunotherapy. Can you be a candidate to use immunotherapy along with chemotherapy? As the hormone-based therapies, the HER2 therapies are not going to be functional with TNBC. And then lastly, are you positive for the BRCA gene? Because this opens up a whole realm of options in terms of what we call PARP inhibitors, especially if you've received or seen chemotherapy before. So now, in terms of advanced TNBC, we really want to understand the role of PD-L1 in today's treatment paradigms. And so PD-L1 stands for the programmed cell death ligand 1. And that's a mouthful to say, so we say PD-L1. And what that is, if you can see here on this diagram, is PD-L1, the ligand, which is, ligands and receptors basically refer to the key and the lock receptors. The ligand is on the tumor cells, and this basically, once engaged with your body's immune system, as represented by a T cell here, basically is a pass for the cancer to go into camouflage mode. And so the immune system cannot recognize the cancer cell, and so it escapes. like a con artist. It just escapes the immune system. And so the advent of these immune checkpoint inhibitors basically block this ligand, this key to this receptor. So there's various different types of drugs that bind either to the tumor cell or to your immune cell. But basically, when they block that connection there through this immune checkpoint inhibitor, that basically, cancels the cancer's ability to hide itself and escape what we call immunosurveillance. So it's basically like the police, your body's immune system can now see all the cancer cells and go to work of trying to kill the cancer cells. That's a simplified version, but that's essentially how we've been able to make some really remarkable strides in treating triple negative breast cancer by hacking this mechanism. Because before that, all we had was chemotherapy alone. Now, importantly, the use of this drug in metastatic disease, unlike in some early stage cases, tends to be limited to patients who are what we consider PD-L1 positive. And what does that mean? Well, your doctor might send a sample of your tissue, on rebiopsy from a new lesion or an old or the original for analysis. And the what we call the assays or the tests that evaluate that are actually based on the individual drug. And so there's two drugs, pembrolizumab or Keytruda or atezolizumab or Tecentriq, that have approval for testing. And they have both their different ways of analyzing what percentage of PD-L1 is prevalent. And so you need a minimum level of this to be qualified for treatment. And as I show you here, it's typically in combination. It is in combination with chemotherapy. And so pembrolizumab or Keytruda plus chemotherapy is one option for PD-L1 positive patients. And then atezolizumab plus nab-paclitaxel has been shown. It was one of the landmark trials in Passion 130 that showed indeed that patients who were randomized to the combination of chemo plus atezolizumab had longer overall survival and progression-free survival. Now, interestingly, they did a follow-up study where they were trying to see, well, can you use a substitute chemotherapy backbone without the NAB component, just what we call paclitaxel alone, which is very common, more readily maybe available. And unfortunately, there was no overall survival or progression-free survival benefit. And so, the FDA put out a message that, we really can only use this combination with the NAB paclitaxel. So now moving on in terms of PD-L1 negative tumors, what do we do here? Well, as we have done in the past, our standard is to typically go through chemotherapy one agent at a time. And now you might think, well, isn't two better than one? Is it more better than one? Actually, no. Unless you have, rapidly progressive, what we call visceral disease, single agent sequential therapy tends to allow you to maximize the use of each medication to essentially, as the goal to control the disease. So these are some agents you may have heard of: paclitaxel, capecitabine, platinum agents, etc. And so the decision to use an individual drug is based on your medical history and your health and your lifestyle, all those things combined. Now, in terms of the third arm that we discussed for the treatment of advanced triple negative breast cancer, patients who are BRCA positive fall into their own special subset. And so PARP inhibitors are basically, they're the approved therapies to work with patients who have BRCA positive or BRCA mutations. And how does that work? Well, it goes down to what the BRCA genes are themselves. They were essentially tumor suppressor genes. And so they work, when they're normally functioning, they help to repair DNA damage. But when they're not functioning, they allow DNA mutations to occur, which explains some of the increased incidence of cancer development. Now, PARP is something that also allows to help repair the single-strand DNA break in the normal cell and a cancerous cell. But if you give a medication, such as a PARP inhibitor, this basically it disallows the cancer to repair itself and essentially allows them to die. So it basically just facilitates cell death in a cancer cell. So fortunately, we found that in patients with BRCA mutations, these inhibitors can work very well in terms of improving outcomes and minimizing side effects that you might see with chemotherapy, with especially in patients who've had prior chemo. So either in the neoadjuvant or prior to surgery setting, post-surgery setting, or even metastatic setting. There are a couple trials, the Olympia AD and the BRCA trial, with in the subsets that had metastatic triple-negative breast cancer, showing that these drugs, some of the brand names, or Lynparza or olaparib or talazoparib, did improve progression-free survival or surviving without the breast cancer returning or progressing. Now, finally, in terms of later line therapies beyond chemo, immunotherapy, et cetera, if you've gone through the whole rigmarole, the good news is that we have newer novel agents. One of the most recent ones is something called sacituzumab govitecan, a mouthful, or the brand name is Trodelvy. But essentially what that is it targets a protein called TROP2, which happens to be prevalent in triple-negative breast cancer, to deliver an active chemo metabolite called SN38. That might sound like gibberish to you, but it's a derivative of a chemotherapy called irinotecan. And so it essentially it delivers a payload of this sort of toxin to the cancer cell. And it essentially can be used after 2 prior lines of therapy. It initially was thought to be 3rd line, but now the indication has been revised to include neoadjuvant. If you received chemotherapy in the neoadjuvant setting, you can then use it, and one in the metastatic setting, you can use it as a 2nd line possibility. And studies have so far shown a pretty we consider a reasonable response rate of 33%. And some of the side effects, however, do include things like gastrointestinal side effects, diarrhea, and neutropenia. Genetic testing is very important in treatment planning. The therapies, in terms of the therapies you get initially, can affect treatment options later. And then finally, as we mentioned with Sarah, PD-L1 BRCA testing guide the current treatment paradigms. And then in the circuit, there's sacituzumab govitecan as a TROP2 targeting agent that can be used after 2 lines of prior therapy.
Wow, thank you, Dr. Pathak, for the great information that you have given us today. We will have a 5 minutes per Q&A. So any questions you have that you would like addressed, please put them in the chat box for us to have answered for you.